All right, welcome back. Today, we're doing something a little different. We're diving headfirst into the hot seat of a consultant-level oral board exam. Now, to make this work, I'm going to be playing both roles here, the tough examiner and the candidate on the spot. We're going to break down a really complex surgical case, not just as a study, but as a masterclass in how you need to think when the pressure's on. Let's get started.
Okay, so here's our roadmap. We're going to follow the exact flow of a real Viva exam. We start with the initial presentation, move through diagnosis, handle a classic exam curveball, plan the surgery, and then cover the long-term follow-up. In these exams, having a solid structure isn't just nice to have, it's everything. It's how you stand control. Let's see how our candidate does.
All right, examiner hat is officially on. So, picture this. You're in the exam room, the clock is ticking, and this is what you get. It always starts with something that seems simple, but you've got to be listening for every single detail. And there it is. A super common, intentionally broad opening line. The examiner is not just giving you a case, they're testing you. They want to see if you're going to build a proper clinical picture from the ground up, or if you're going to jump to conclusions. Let's hear how our candidate feels this. This is that classic wide-open question, how will you approach this? The absolute worst thing you can do right now is blurt out a diagnosis. What they're looking for is a safe, systematic process. They want to hear you say you'll stabilize the patient first, and then gather your data methodically.
Okay, so after going through the motions of a full history and exam, here's the summary you'd present back to the examiner. You have to pull out the most important pieces of information. Notice the red flags we've highlighted? The patient looks sick, she has a high fever, a fast heart rate. Those are systemic signs. And then you have the really concerning parts of the history, that unintentional weight loss and chronic constipation. This is where the story starts to take shape.
So now that we've got our initial data points, it is time to build our differential diagnosis. This isn't just about listing everything you can think of. It's about showing you can prioritize what's most likely and what's most dangerous.
So, the examiner wants a list, but it has to be a smart list. You need to lead with your number one suspicion based on the evidence, but then you absolutely have to include the other big scary things that you cannot afford to miss.
And this is a really solid list. You know, for a 52-year-old with left lower quadrant pain and fever, diverticulitis is absolutely number one. But, and this is a huge but that shows you're thinking at a higher level, that weight loss is a massive red flag. That's why colonic neoplasm, cancer, has to be right there at number 2. The others are definitely possible, but for now they're further down the list. All right, next question. The examiner wants your plan of attack. And again, this isn't a memory game of listing every test you know. They want a targeted strategy. Every single test you order needs to have a specific reason behind it. So the labs come back and whoa, a couple of these numbers just leap off the page. A white blood cell count of 23,000? That's screaming serious infection. But just as scary is that glucose of 443. That tells us her diabetes is way out of control, and that's a huge problem. It's going to make it much harder for her body to fight this infection and to heal from literally anything we do. And here it is, the smoking gun. The CT scan basically confirms what we were thinking. That fat stranding is just a radiologist's way of saying there's inflammation around the colon. But the real kicker is that big collection of fluid with air bubbles in it. That is an abscess, plain and simple. Now, the good news is that it says no pneumoperitoneum, which means the colon hasn't burst open into the main abdominal cavity.
So now, with that CT report in hand, I can give a very precise diagnosis. It's not just diverticulitis, it's complicated diverticulitis. And by specifically classifying it as Hinchy stage 2, which tells the examiner, I know this means a contained abscess, I'm showing I understand the specific classification systems. And that's critical because this stage is what tells us what to do next.
Okay, so up to this point, this is pretty much a textbook case. But in board exams, and definitely in real life, it's rarely this straightforward. The examiner is getting ready to throw a wrench in the works to see if I can think on my feet. But before we get to that twist, I have to show that I know how to manage this Hinchy 2 abscess. The standard of care here is to try and avoid surgery up front. So we're going to get her admitted, give her IV fluids and antibiotics, and most importantly, we're going to call our friends in interventional radiology to stick a drain in that abscess. This is all about getting source control, killing the infection without a huge operation. And there's the twist. The drain worked, the abscess is gone, the patient feels better, but something is still there on the scan. Is it just leftover inflammation, or is it something much worse that was hiding underneath? The examiner wants to know my next move, and honestly, there is only one correct answer here. You have to get a piece of that tissue. You need a biopsy.
And boom, this is exactly why every patient needs follow-up imaging and a colonoscopy after a bad bout of diverticulitis. The biopsy comes back and it's going cancer. This was never a simple infection. This was a cancer that perforated and created an abscess, fooling everyone. The whole game has just changed. We've gone from an infection case to a cancer case.
So, with that bombshell diagnosis, our whole plan has to pivot. We're not just thinking about infection anymore. We need a full-blown cancer staging workup, and we need to plan a definitive operation. Let's see how our candidate handles this critical next phase. Okay, first things first, a full staging workup. We get a CAT scan, that's a CT of the chest, abdomen, and pelvis. And the good news is we don't see any obvious spread to the liver or lungs. But the CEA, which is a tumor marker, is sky high at 339. A number that high is almost certainly from the colon cancer. So putting it all together, we're looking at a clinical stage 3 cancer.
Now for the surgical plan. This has to be crystal clear. The operation is a left hemicolectomy with a sigmoidectomy. And I would make sure to tell the examiner that this is an oncologic resection. That means I'm not just cutting out the tumor, I'm taking a wide margin of healthy colon on both sides, and critically, I'm removing the entire packet of lymph nodes that drains that area. The second goal, if possible, is to hook the two ends of the colon back together.
So the surgery is done, but for any cancer patient, that's really just the beginning of a much longer road. The exam isn't over until I've clearly laid out my plan for her postoperative care, and just as importantly, her long-term surveillance.
And then the final pathology report comes back. And it's not good news. This is a very aggressive tumor. T4 means it was growing through the wall of the colon. Poorly differentiated means the cells look very abnormal and aggressive. And it has both lymphovascular and perineural invasion, which means the cancer is already trying to spread through blood vessels and nerves. To top it off, 7 of the 13 lymph nodes we took out had cancer in them. This report tells us she is at very high risk of recurrence.
And this is it, the last big question. What now? Given how bad that pathology report is, the examiner wants to know that I understand this isn't just a surgical problem anymore. My answer needs to show an understanding of team-based cancer care. Well, the very first thing that has to happen is an immediate referral to medical oncology. With a pathology report like that, she absolutely needs adjuvant chemotherapy to try and kill any microscopic cancer cells that might be floating around. After she recovers from that, she begins a very strict surveillance schedule. We're talking frequent clinic visits and CEA blood tests, yearly scans, and regular colonoscopies. Our job now is to watch her like a hawk to catch any potential recurrence as early as humanly possible.
And for the final curveball, a recurrence. 2 years later, a spot shows up in her liver. What's the guiding principle now? And the answer isn't a specific drug or operation. The guiding principle is the multidisciplinary tumor board. This is no longer one surgeon's patient. This requires a meeting with medical oncologists, liver surgeons, and interventional radiologists to figure out the best path forward. Because even when cancer comes back, the goal is always to find a path toward a cure. And today, that can only be done as a team. And that's a powerful lesson to end on.